Hello and welcome to this discussion on the public health information infrastructure. In this discussion, I'd like to cover some of the main components that we think about when we think about information that we use for public health. And so starting off, let's discuss some of the places that data might come from. Now, data is the individual information pieces that we can use to try to create a better picture of how public health is doing. And we get that data from all kinds of places. First of all, we might get some information from our vital statistics system, and that is one of the tasks of the public health department is collecting information on birth and death. And one of the key advantages of the vital statistics system is that it is thought to be nearly complete. And by nearly complete, that just means that for most people who are born or die, we have information on them. It's a rare reason that we would not have birth or death data. And if you think about it, there are several systems of collecting data that are not nearly as comprehensive as birth and death, and that's because we want to know about what happens to pretty much every single person. And so for most people that are born, even if they are not born in a hospital, they still end up getting a birth certificate. And for most people who die, they end up having a death certificate, even if that does not happen under the care of a physician or within a medical facility. We still have a death certificate that goes along with that death. So those are thought to be nearly complete. The next kind of data we may deal with are disease registries, and one of the ones that's close to home for us here at Loma Linda is the California Cancer Registry. Dr. John Morgan heads that, and he brings a lot of expertise, and so cancer is a common thing that we may keep track of. There are Alzheimer's data, there are stroke registries. We keep registries of all different kinds of things. Another kind of thing that we keep track of is what we consider to be surveillance data, and usually that's thought of in terms of infectious disease. We have surveillance of what we call reportable infectious diseases that are required to be reported to health departments. And those are as good as we can possibly get them to be nearly complete, but one of the downsides is that if somebody has cancer or has an infectious disease, it may not end up getting reported to either that disease registry or the surveillance system in the health department. Part of that is because the reportable diseases depend on the physician or the hospital or the laboratory to identify what it is, and then to use their own systems, the hospital or the clinic or the lab, to report that. That's called passive surveillance. And with passive surveillance, what that means is that the health department, or whatever the surveillance system is, sets up this great surveillance system. They create policies around who's supposed to give them information, and then they sit and wait for that information to come in. In other words, they're passively waiting for that information to arrive. On the other hand, an active surveillance system would mean that the person who sets up the surveillance system actually goes out and collects that information. They actively spend energy gathering the data that they need. And as you can imagine, an active surveillance system is much more expensive. And so that's why often county health departments depend on passive surveillance to collect the information that they need. With periodic surveys, those could be telephone surveys, they can be examination surveys. NHANES, NHANES, the National Health and Nutrition Examination Survey, is a common one that we think of when we think about periodic surveys, and that's on the national level, but there are a variety of state and more local endeavors where they collect information on a regular basis. So those surveys collect information that can be that can help us see longitudinally over years and decades how the health of the population changes. And as you can probably imagine, that does not attempt to capture everybody in the population. They have to be a smaller subset, so they use sampling techniques to try to capture what would be representative of the population. Program management also comes in all different kinds of shapes and sizes. A typical one would be like a WIC, Women, Infants, and Children program, where maybe they want to collect information about their own program and how they're doing, what kinds of services they're providing, what kinds of clients they have that they're serving, and so they would like to know for their own program management and evaluation how they're doing. Another big category is clinical or big data, and I've lumped them here together. We often have a whole slew of information that we get just because we're collecting information on hospital inpatient, hospital outpatient, all kinds of clinic data that we collect. There are databases that try to collect information on a much wider scale. Those usually are just a sampling of inpatient and outpatient experiences. Some try to be more complete than others. But there is another big data component, and that is the census. And I'm not sure a lot of people think of it as big data, but the census attempts to capture nearly everyone in the United States every 10 years. And so if you think about it in that respect, we're really trying to capture a basic information on every single person. So again, this one is trying to be nearly complete. And often that census data is what we depend on for what we call our denominator data. If we're doing any kind of a study of the population and we need to have a sense of how many people out there are of a specific subset, how many women of a certain age, ages 18 to 35, say childbearing age, or we need to know how many children we have in each of the different age ranges, we will depend on the census to give us that denominator data, and that's considered to be nearly complete. The primary people who somehow get missed disproportionately are homeless individuals, and so we may not have 100% complete, but it is still as close as we can get. And the other reason that census data may be incomplete for whatever we're trying to study is if you have rapidly shifting changes in that particular population. Say you have in a specific city or an area of a city, you have a certain subgroup of people that are growing or neighborhoods that are expanding extremely quickly. We've seen this in our own Southern California area in Palm Spring. There are whole entire little sub areas in the city where 3-4 years ago when the census was conducted, there were no people who lived there. There were no streets, there were no houses, there was nothing. It was just a desert. And then all of a sudden up springs a whole entire neighborhood and development, and you have a whole bunch of either a whole wealthy neighborhood or a whole poor neighborhood that is just kind of sprung up out of nowhere. And so our census data doesn't always perfectly describe an area, but it's the best we can do. So when we're looking for denominator data, a lot of times we'll go to the census. So I want to use an example of some of the challenges that we have with the public health information infrastructure. As you can see, we have a really wide variety of programs, people, areas that are collecting data. And the data is not always collected in such a way that it can talk to each other. So our vital statistics data may not always talk to the disease registry data. And the periodic surveys may not talk with the surveillance data or the program management data, or the data may be collected in such a way that the questions are asked differently about age or date of birth or race, ethnicity, or gender, and we want to be able to get a really comprehensive picture of what's happening, but we have all these different kinds of data systems. One example of that is where we have what's called the Public Health Information Network, and that is one of the places where we track things such as animal disease data and vector control information. Then we have what's called the Nationwide Health Information Network, and that tracks more things, that's data about patient records, health records, other kinds of data related to patients. And so what those two networks have tried to do is, since the Nationwide Health Information Network is trying to capture information about the diseases that might be spread by animals or vectors, they've tried to standardize things in terms of their vocabulary, the way things are defined, the directories, even if they can standardize things like security and the way they message things. And so then they'll be able to share information across, and they'll be able to create one data network where you can actually have that information and answer questions that neither of the individual databases would be able to answer. And part of the way that they do that is by using a secure cloud that is secure behind a firewall that only public health and health information networks can get behind, or at least that's the idea, we hope. So by having this secure network, then they can share information back and forth between all these different kinds of data. And this is just a sampling of all the data that's out there. There are so many different kinds of data that we have available to us that we could answer certain questions. So that is a little introduction to the public health information infrastructure. Next, we will look at some of the theories and strategies that we use in informatics.